So it is one of the most common just a minute. Ah, it is one of the most common cause of the radial sided wrist pain, especially in the elderly age group population. And we see in the middle age group person also. They commonly present with the pain, weakness of the pinch, and deformity. As you can see, there is some prominence at the CMC joint along with the tenderness. And when you do the mobility test, there is a grinding sensation which indicates a wearing of the cartilage, and the two ends of the bone are touching and grinding each other. So, and followed by there is a decrease in the pinch strength, as well as a decrease in the range of motion because of secondary development of the fibrosis along the arthritic joint. So how do you do that? How do you manage this type of patients? So the most important thing along with the clinical symptomatology, way of presentation is to diagnose what is going on is the radiology. As Vipin has pointed out the importance of the various views, here the Robert view is very, very important. When you do a hyperpronation view, you can see the CMC joint very nicely over here. You can see that joint is subluxating. Besides the standardized view, which is AP and lateral, which shows the arthritic changes in the joint. Having a CMC joint Roberts view is very important in actually classifying the stage of disease. You can see the joint is subluxating out. Then another view is a stress view. You put the stress on both the MP joint and apply lateral pressure on each side, and you can see the joint is little bit subluxating over here on the left hand side. So how do you do the staging? Well, in stage 1, the articular contour is normal. The XY absolutely look normal. There may be a joint subluxation like this, or there may be a joint space widening because of secondary synovitis and increase in the fluid in the joint. And what we see in the stage 2 is that there is a slight narrowing of the joint. There may or may not be sclerosis, and the joint debris, that is osteophytes and secondary bone formation, are usually less than 2 millimeter size. When you have a further higher staging, the joint debris increase in the size more than 2 millimeter. And to differentiate with the stage 4, you have to see what is going on with the ST joint. The scaphoid trapezoid joint is looking normal. These all views you can assess this thing in the Roberts view. So again, the radiology is very important. And what you find in the stage 4, that is a pantrapezial arthritis. There is a arthritis above and below the trapezium. You see there is a narrowing of the joint space between the scaphoid and the trapezium, and there is a complete loss of the joint space between the first metacarpal and the trapezium. So having classified the disease, what would you do with the patient? Of course, a non-operative treatment is essentially tried in the form of splints. You can give the NSAID, which reduces the inflammation of the joint, and you can put the joint local steroid injection in the joint. Swigart, in his study, found that 3 weeks of the full-time splintage plus 3 weeks of the weaning period of splintage usually give 76 and 75% reduction in the symptoms, so that the patient defer the surgery in a stage 3 and stage 4 of the CMC joint. So a non-operative treatment is worth trying before offering any surgery, irrespective of your radiological classification of the disease. What other else think? You have to have an activity modification. This is just a funny example of activity modification. There are various ways. Like you are a housewife, you can increase the thickness of the knife handle. You are writing with the pen. You can increase the thickness of a pen by, or you can have a thicker pen so that the lot of pressure is not borne on the CMC joint, and your grip becomes much relaxed. So having said that, if all the conservative trial fails, like local steroid injection, activity modification, splintage, all this fails and the patient continue to have a problem with the pain, not able to do the activity of daily living, the surgical management comes to the next. So it all depends what surgery you are offering. It depends upon the demand of the hand, what is the occupation, what is the age, and how is the going to use the hand in the future. Of course, the staging of disease is the foremost important thing in offering any treatment. Simultaneously, in the clinical examination, whenever you are doing the surgery, just look for the MP joint collapse deformity. The MP joint has not gone into the hyperextension. Having said that, if you just correct the CMC joint problem and not looked at the MP joint deformity, a, surgical correction is going to shift your problem from CMC joint to the MP joint, and patient will never be happy for his surgical outcome. This is an example of stage 1 and at least stage 2. This is the X-ray we have shown over here. There is a joint is subluxated. Patient is quite young, and he's an officer, and he's not able to, not exactly not able to write, but he was having a lot of problem in writing and doing the office work. So when we assess the thing, there is an instability. There is no history of trauma. These are the patients who are early precursor for development of the CMC joint arthritis. So FCR ligament reconstruction of the instability was done in this patient. Another example of the same, who is in the subluxation of the joint at the age of 40 years, come with the CMC joint pain with no history of trauma, no other inflammatory disorders. So these are the patients who are in the stage 1 and probably can be taken care by the ligamentous stabilization procedure. This is a clinical assessment of the patient who have a subluxation of the joint, painful joint, no history of trauma, and having a pain of chronic duration. And they have a difficulty in fine motor activity because of the pain. These are the patients who are in stage 1, can be treated by ligamentous reconstruction. It's one of the example of a girl who had a similar type of situation and had a bilateral ligamentous reconstruction. You can see there is a hole for the FCR ligamentous reconstruction, and these are the movements she is having post-op. And of course, no pain. She came for the pain management. There is no pain. The movement was normal since the beginning. So what you do in the stage 2, late stage 2 and 3, young physiological age, high demand hand, isolated CMC joint orthodesis is the treatment of the choice in the heavy manual laborer. Having said that, LRTI, I will come to it later on, is also a good choice. This is one example who is a farmer by occupation, having a type, I would say late stage 2 arthritis, had a fusion of the CMC joint. And what are the contraindication for the fusion? Again, I said that pantrapezial arthritis should not be there. So it's not there in the stage 2. The bone stock should not be poor. And profession requiring the fine movement of the thumb should not be offered orthodesis surgery. When you have a low demand of the hand who requires movement, middle age group, I would consider ligamentous reconstruction, tendon interposition, orthoplasty. And in elderly age group, you can straightforward do a simple trapeziectomy, LRTI. However, there are different methodology of treatment is also available. I will come to it in later of this part of the lecture. When you have a stage 4, that is CMC and STT arthritis, you can just do a simple trapeziectomy. You can do a LRTI also. You can do a mini tightrope. Mini tightrope is what? You excise the trapezium, then you suspend by minimal incision procedure to the first metacarpal to the second metacarpal in appropriate tension, so the problem of subsidence doesn't occur. This is a follow-up of a lady who had a LRTI about 5 years back, and now you see there is a good joint formation between the first metacarpal and the scaphoid. There is no arthritic changes and no pain over here. This is one of the example who is a post office clerk having a bilateral, because he has to lift the files every day, large amount of files every day, is a bilateral CMC joint arthritis. You can see there is a complete loss of the joint space, and he has a bilateral excision of the trapezium, simple trapezium excision, and you can see the follow-up. The left hand side is around 7-year-old follow-up. I think it had done in 2013, and the right hand side is a 5-year-old follow-up. You can see the grip strength. But simultaneously you see there is a laxity of the first CMC joint. So a patient who is more concerned about the laxity, which is not of clinical significance, I may offer the LRT. I have to do the counseling with the patient. Your pain will go away, but you will see some abnormal mobility at the base. So what is going on world over? The initial treatment started with the simple trapeziectomy. People find it out that the laxity is not good, we can offer a better treatment, then the LRTI come into the procedure. Then because of later subsidence, which was again of no clinical significance, joint replacement, partial trapeziectomy, allograft, etc. comes into the procedure. But we are circling in the same, we are running in the same circle. We started with the simple trapeziectomy, we went to the LRTI, then realized simple trapeziectomy is really good answer. Then from LRTI, we got to the joint replacement, again coming back to the simple trapeziectomy. So what is more, the less is more in this type of cases. So what is the evidence? It's published in Journal of Hand Surgery. 5 to 18-year follow-up for the treatment of trapeziometacarpal arthritis, a prospective comparison of excision, tendon interposition, and ligamentous reconstruction and tendon interposition. What was the conclusion? Just look at this 3 line. The outcome of all the 3 variants of trapeziectomy were similar after a minimal follow-up of 5 years. There appears to be no benefit of tendon interposition and ligamentous reconstruction in a longer term. Remember the term, in a longer term. But the certain procedure has an advantage in a shorter period of time. Like if you want to have early rehabilitation, LRTI is superior than the just doing a trapeziectomy. And adding a tightrope again becomes an early rehabilitation advantage. What are the complications with the surgery? There are injury to the superficial sensory nerve, which is possible, arthrogenic metacarpal base fracture, graft excursion, late MP joint collapse with the pain, proximal thumb metacarpal subsidence with painful instability, and dorsal CMC joint subluxation with pain, which we commonly see in a simple trapeziectomy, but I have not seen any recurrence of pain by doing only simple trapeziectomy. Thank you very much for your patience listening.